I'm Matt Avery. I work for FHI 360 on the PEPFAR-funded USAID linkages project in Thailand. I was asked to give sort of a broad overview on what we mean when we talk about key population empowerment and to share some experiences from the field in countries across the region. I was told to do this in 15 minutes, but I was also told to speak slowly. So we'll see how this goes. Wait, how do I? All right. No, not like that. Okay, this is getting worse. How do I go backwards? Ah. Perfect. Okay, off to a good start. No. Off to a worse start. Okay. Thank you. Okay. So I wanted to start just by noting I have no conflicts of interest, and as a broad overview, I'm going to talk just a little bit about what we mean by key populations for people in the room who might not be familiar with this sort of terminology. I'm going to share very, very briefly three project models from the field, one around peer-driven interventions to engage with key populations, one around working with members of key populations on co-creation for meaningful messaging, and then I'm going to talk a little bit about task shifting across the cascade under a KP-led model. These are going to be really broad overviews, and I think my co-speakers are going to do more of a deep dive into some of these different approaches. I've got a few key lessons learned I want to share at the end of the presentation if I get there with enough time. Just to review really quickly, when we say key populations, we're talking about the people who are at the highest risk of becoming infected with HIV or transmitting HIV onwards to their partners. The populations up on the screen globally account for roughly half of all new HIV infections every year, though here in Asia, in a concentrated epidemic setting, they account for as much as 80% of new HIV infections. And the reason we're so concerned about these populations is not only because they're at much higher risk of becoming infected or of passing on infection, but based on the best available data we have, they're also much less likely to access services for HIV testing, prevention, care, and treatment than are members of the general populations. So sort of globally, for those key populations, we're not remotely close to achieving the 90-90-90 targets for any of them. We're far below where we need to be. Reasons for that, improvements in service uptake across the HIV cascade are hindered by a number of barriers that are pretty consistent across countries and regions, including stigma towards members of key populations, and that includes self-stigma among key populations themselves, discrimination, punitive legal environments, and unsupported policy environments that keep people from being able to access the services they need when they need them so that they can protect their health. So that's key populations, but this is a session on key population empowerment, and what do I mean by empowerment? There are lots of different definitions of empowerment. I'm not about to start that argument now. I'm going to say broadly, empowerment refers to measures designed to increase autonomy and self-determination of individuals and communities, including key population communities. It's to help people overcome their sense of powerlessness or their feeling that they lack influence. It's to help individuals and communities recognize and know how to use their own resources and act on their own authority so that they can represent their interest, claim their rights, and claim control of their lives. And again, that's in terms of speaking about individuals, but it's also talking about acting collectively as members of communities. The project that I work for, Linkages, one of our key aims globally is empowering key population communities to improve their access to and uptake of HIV services across the prevention, treatment, and testing cascade. So this is core to what we do, and what I want to spend most of my time this morning doing is sharing three project examples of how we're trying to do that. The first is around empowering key population clients to work for their communities and help bring more people in for HIV services. And so what you can see up on the screen, this is a model we call enhanced peer outreach, or in some countries we call it the enhanced peer outreach approach. And this is a peer-driven model where when we recruit members of key populations to give them HIV information, to distribute prevention commodities, to refer people to testing, we then ask those clients to go back to their communities, to go to their partners, to go to their friends, and educate more people and refer more people in for testing, and to do this not as official members of our projects, but to do this as members of their communities who are working to better the overall health of their communities. So it's essentially a snowball recruitment model where we recruit clients who recruit their friends who recruit their friends. And some of you who have research backgrounds might be looking at this and saying, oh, this is respondent-driven sampling. I would say yes and no. It's a respondent-driven recruitment approach, but it's not sampling. And the reason it's not sampling is that usually under a respondent-driven sampling model, your aim is to recruit an unbiased representative sample of your target population. With this approach, we are not trying to be representative. We are very much biased. We are trying to recruit a sample of individuals that is skewed as much as possible towards the highest risk individuals in our target population, so that we test people, find more HIV positive cases, and get people on treatment early. Or if they're high risk and negative, get them access to PrEP early. Just to show you, I could show you examples from any one of 30 countries around the world that are using this model. I wanted to show you data from 1 year of implementing this enhanced outreach approach in Indonesia. And the reason I picked Indonesia is we actually have a sort of a natural comparison in Indonesia within Jakarta, where over 1 year we were able to compare results for an enhanced peer outreach approach with results from a sort of traditional community-based professional outreach worker based approach in terms of testing, uptake, and case finding. And what you can see is over time, consistently, the enhanced peer outreach approach that was peer driven outperformed traditional outreach in terms of the number of people reached, the number of people tested, and the rate at which people tested were found HIV positive. So we found higher case finding rates consistently. And while the case finding rates for the traditional outreach approach remained more or less stable over time, the case finding rates in the enhanced peer outreach approach increased quarter on quarter. And the reason they increased was because we were working very closely with our key population clients to become progressively more strategic in our targeting, to figure out who are the highest risk individuals, who do we need to be talking to about testing, so that we saw testing yield increasing over time. So that's, again, this is very superficial, and I apologize for that, but that's a brief introduction to empowering members of key population communities to reach out to their partners and bring them in for testing. I want to move on to a second, oh, no, I'm going to skip that. I want to move on to a second model, which is co-creation. So this is moving beyond just using members of key populations to reach our target audiences. When we talk about co-creation, we're talking about working with members of key populations to figure out how best to reach and serve members of our target audiences, how best to message them, what services are best to provide to them. So using the access that key population clients have to better understand how we can work with these audiences. A broad definition of co-creation would really be about a process of collaboration between experts, like what we think we are at FHI 360, stakeholders, and members of our target audiences to develop new value. And that value might be in the form of a new concept. It could be a new solution to a problem. It might be a new product, or it might be a new service or an improvement to an existing service. And the example that I'm going to share is actually working with members of key populations to co-create new messaging. Co-creation is not a new idea. Anyone at this conference this week who used Wikipedia at any point when they were putting together their presentation knows what co-creation is. We've all worked with co-creation products. In the health field, co-creation has been used to shape a broad range of health interventions, from cardiac arrest to cancer to HIV and sexual health. There has been research that has shown that audiences sometimes prefer co-created messages or co-created services. And there's a growing body of evidence around the effectiveness and, in some cases, cost savings when you use co-created or crowdsourced health promotion models or health intervention models. And I want to share just one example. And again, I didn't realize this until this morning. I'm going back to Indonesia again. I swear, the Indonesia team did not pay me to do this. They just have good examples. So I wanted to share a brief story, and I'm calling this Co-Creation in a crisis. Because the Linkages Indonesia team works very closely with a team of social media influencers drawn from our target populations. They have worked closely together with those social media influencers to come up with HIV education and testing promotion campaigns. And essentially that collaboration was Linkages made sure that the facts were correct. Our social media influencers told us how to communicate those facts. They came up with the models, they came up with the messages, they came up with the images. They said, we are the experts at communicating with these audiences, not you. So let us do this, and we did. One of our influencers, the woman you're seeing up on the screen now, Andrea, or as she's known on Instagram, Cat Womanizer, is a lifestyle influencer. She has had over 30,000 followers on Instagram, and she focused, her online brand was around dating, sexual health, and human rights. So she was one of a group of individuals that we partnered with to promote HIV messaging for members of our key populations. Now, in the process of implementing this campaign, one of Andrea's followers posted a story to her about going to get a facial at a spa and being infected with HIV at the spa because she got the facial. And Andrea reposted that, and what happened with 30,000 followers is that this story went viral very quickly. It exploded across social media. It jumped from Instagram to Twitter to Facebook. It was then picked up by local media. It was then picked up by CNN and broadcast internationally. This firestorm on Indonesian social media about how you can get HIV if you go to a spa and get a facial. Andrea saw this happening, came back to Linkages and said, what can we do? We provided her with appropriate information on HIV transmission. She came up with the strategy for how I'm going to get this message out to my followers. So she pushed out counter messaging that she designed herself to address these misconceptions around how HIV can be transmitted. It worked out really well for her. She went from having 30,000 followers when this campaign started to over 70,000 followers when the campaign ended. And it was largely driven by the viral spread of this sort of scandal around getting HIV from a facial. So she was able to bring in a lot more new followers and educate a huge number of people on how HIV is really transmitted and what some of the misconceptions around HIV transmission are. The nice thing for her is that once she brought in those followers, they stayed. They stayed because they like her brand, they like her messaging, and they like the new information that they're able to get that Linkages helps Andrea to push out. But this didn't work well just for her. It worked really well for us as well, because over the life of this campaign, we were able to refer over 12,000 clients to an online self-risk assessment platform. Andrea herself was responsible for more than half of all of the clients who were referred to that risk assessment engine. Of the 12,000 who completed a risk assessment, almost 800 booked an HIV test online. Now, more people may have been tested who didn't book an appointment, but we had 800 who made a reservation for an HIV test. And at 9 participating HIV testing clinics in Jakarta, over the course of this campaign, we saw a 58% increase in HIV case finding, largely attributable to this online, co-created, crowdsourced messaging around HIV. And again, I could talk about crowdsourced messaging in a number of countries around the world. I just think that Andrea has a really good story for how crowdsourcing and co-created content can really reach target audiences and motivate them in a way that we sometimes can't with purely public health messaging. The last model that I want to share is really taking it a step further, taking it just beyond reaching and communicating with audiences and empowering members of key populations to provide services for members of our target populations, for members of their communities. So in Thailand, we're supporting a model in collaboration with the Thai Red Cross called a key population-led health services model. This is a model where we are task shifting HIV services from the public sector into communities where they are delivered by lay health workers who are members of KP-led community-based organizations. All of these services adhere to Ministry of Public Health standards, but they're designed and delivered by KPs themselves, which means they are differentiated based on the needs of clients, and they're client-centered and demand-driven. So we're focusing on not just delivering the services we think are critical, but delivering the services that our audiences are telling us they need. And I think that when my co-panelist, Rena, gets up, she's going to talk a little bit about how that has worked in transgender populations in Thailand. So I don't want to go too much into that. But just to show you what this looks like, and I know the graphic is a little bit complicated, but I still really like this image of key population-led health services as the key that we can use to unlock improvements in HIV service delivery. So this model includes expanded reach through peer-driven outreach with our enhanced peer outreach approach. It includes demand generation, which we do in partnership with communities using co-created messages and materials, but it doesn't stop there because it also includes multiple approaches to HIV testing, including community-based testing, mobile testing and hotspots, and oral fluid self-testing and assisted self-testing with lay health workers. It includes peer navigation so that positive clients can get rapid ART initiation and can be monitored on ART in communities under a differentiated services delivery model. It includes, for those who test negative, options for HIV prevention, including, yes, distribution of condoms and lubes, but also including community-based PEP and PrEP that are delivered by lay health workers. And it includes KP-led adherence and ongoing support for retention, again, through peer navigators and lay health workers in the communities. So the whole idea of KP-led health services is that our clients are sometimes best served in the communities they come from by members of their own communities who understand their challenges, wants, and needs, and we're able to demonstrate that this is something that in fact is possible. And to show you some of the outcomes of this, since we launched the KPLHS model in Thailand, we've seen year-on-year improvements in the number of people tested, the number of positive cases identified, the number of people getting on treatment. Between fiscal year 2017 and fiscal year 2018, we saw a doubling in the number of KP clients who were tested under the KPLHS model, and we saw a 115% increase in treatment initiation among KPLHS clients. So it's at the level of the project, it's working. It's allowing us to increase our service delivery and achieve our targets, but it's also having a significant impact at the national level. Because in 2018, 9 KPLHS sites accounted for 55% of all HIV testing among self-reported MSM and transgender women in Thailand. More than half of all testing among these key populations for the entire country was in only 9 community-based clinics under the KPLHS model. A third of all HIV positive cases identified among these populations were attributed to these KPLHS sites. And 55, as of June 2019, so I have very recent data, as of this month, more than half of all Thai PrEP users in Thailand are people who initiated PrEP at KPLHS sites. So this model is not just helping us achieve our program goals, this model is helping the government of Thailand achieve their epidemic control goals for members of key populations. I suspect I may be almost over time. I just had a couple of key messages I wanted to stress at the end. First, as we've seen, there are persistent gaps in HIV service delivery for members of key populations. And if we want to close those gaps, working with communities is critical. But it's not just working with communities to reach individuals, it's working with communities to provide services and retain individuals in the cascade of services over time. I was asked to talk about how we at Linkages empower members of key populations to do this, but I wanted to end with a slightly different message, which is that what we see globally is that key populations are demanding services. This isn't us giving services to key populations, it's key populations demanding access to services that meet their needs. And where we are not providing solutions, they're making their own responses. They're finding their own solutions. We saw this historically with access to HIV medications and activism in communities to increase access and reduce prices. We're seeing it right now with things like PrEP buying clubs, or with the explosion of HIV self-testing kits available in the gray market online in countries where ministries of health have not made the regulatory changes to make HIV self-testing a legally available product. So where we don't provide the services that members of key populations feel that they need, they find ways to get those services without us. So while I was asked to talk about how we empower key populations, I think my final message would be that we, in fact, don't and really cannot empower key populations. Key populations are claiming their own power. And really the question to us is, what can we do to support that? I wanted to end with just a few acknowledgments, especially to acknowledge the support from PEPFAR and USAID under the Linkages Project for the development of all of these models, but also for allowing me to be here today. The data that I presented was not my data. It came from our partners in many countries around the region, and especially from our very special partners at the Thai Red Cross AIDS Research Center in Thailand. I also wanted to acknowledge Joe Tucker and the Social Entrepreneurship to Spur Health, or SESH team, who have wonderful models and great data around co-creation and crowdsourcing that I believe is actually being discussed in another session today that I would encourage anyone who has time to go in here. That's the end of my remarks. Thank you very much.